Hello, good morning. I am proposing you to review the surgical aspects of recurrence because in the end, as I suggested yesterday, the initial surgery is relevant for the outcome of the patients. So despite several attempts to stratify the risk of recurrence, in the end, one of the major factors for recurrence is the initial surgery. The better the initial surgery, the less risk of recurrence you have. So in the next few minutes, we are covering how we understand optimized surgery to prevent the recurrence of papillary thyroid cancer. I will go back to the same slide I showed you yesterday. Already in the 70s, it was clear that the recurrence rate of PTC was pretty high. In fact, in that time, there were about 600 patients included in that initial study by Ernest Massaferi. And as you can see, the recurrence rate reached almost 30% in a 20 years period. Of course, in that study, it was also shown that radioiodine ablation was a good strategy to reduce the recurrence rate. However, this was on top of something that is relevant to discuss, which was the original population where those studies were made. There were 500 patients with papillary and follicular cancer. Many surgeons were involved in that study of the VA hospitals in the States. Different procedures were performed. And that's important for the relevance of the study because now we know that the most extensive procedure will provide the less risk of recurrence. At that time, in the 50s and 60s and even the 70s, there were few surgeons doing total thyroidectomies for cancer. However, this study pointed out two major issues that T was essential to understand recurrence and age. So from that original studies, we should remember that recurrence rates were high, that recurrences were closely related to improper surgery, and that maybe in this context, radioiodine ablation had some positive impact. But what happened after these initial studies? It soon became evident that the recurrence rate was also associated with some well-known risk factors. And the Mayo Clinic and also Blake Keddy already in the late 70s suggested some scoring systems to approach the issue of recurrence. But as you can see here, even with lesser procedures, patients with low-risk cancer had a lot of recurrences, about even 14% for low-risk patients with long-term follow-up, and up to 60% if we did hemithyroidectomies for patients with a high risk. So by the 80s, we knew that the extension of surgery was relevant, and it also, we think, was relevant how we did approach the lymph node resection. Now, what has happened in the last decade after these initial pioneering studies? You can see here a review I made on what I think the most relevant studies on PTC recurrence. And when I talk about PTC recurrence, I am very simple on that. I am a surgeon. It means a structural recurrence requiring reoperation. These patients, mostly in these studies, are patients that required redo surgery because of recurrence. And as you can see, from 1996 to 2014, the prevalence of recurrence for PTC is quite high. This is why yesterday I was saying survival is no longer an issue. Recurrence is still an issue. 27% for Dieter Simon, a surgeon specialized in thyroid surgery in Germany. 8% in most study with a short follow-up, up to 68% in total in memorial. And what is quite interesting, in patients with lateral neck disease, the recurrence rates were pretty high, even in the hands of surgeons that are supposed to do a nice lateral dissection of the neck. Here, that's quite unacceptable to have 60% recurrence after lateral neck dissection. But keep in mind these numbers, because lateral neck involvement is something that bears to this discussion. To 14% for low and high risk 5 years, and to 25% at 10 years for low and high risk. So we have recurrence rates going up to 60%. So still we have a problem there. Now, what are the main factors involved in recurrence? Now, we are not assessing risk, we are assessing factors that we know are involved or influence recurrence rate. Tumor size is essential. I will show you some data on that. The presence and number of positive lymph nodes. The completeness of resection, if the surgeon leaves disease behind, is not just recurrence, it's persistence. The central neck compartment involving the ratio between involved and total resected neck nodes, the extension of surgery, both on the thyroid and on compartment 6, and the presence of lateral lymph node involvement. Tumor size and the presence and number of nodes, we can do nothing about it. So surgeons can do nothing about the tumor size. It's there, or the node involvement. But surgeons can completely resect the lesion, can do a central neck dissection, can do a total thyroidectomy, and can also do a lateral node clearance. So this can be edited by the surgeon. And this will be the focus of my talk. Tumor size is essential. We discussed that yesterday. I will bring today this data from Billy Moria, showing the relevance of recurrence in over 40,000 patients with PTC, going from below 5% for the microcarcinomas up to 25% in patients with tumors over 8 centimeter size. So there's a clear-cut increase of recurrence according to the size of the tumor, probably because they are also associated with more extensive extrathyroidal invasion and also more involvement of the lymph nodes. Extension of surgery is also relevant for all patients dealt with in the study of Billy Moria. The recurrence rate was clearly higher for patients undergoing lobectomy. And this, of course, is consistent with the initial idea of Mazzaferri that the first or second place of recurrence was the contralateral lobe or the remaining thyroid in the patient. But if you look more carefully at Billy Moria's data, the main difference between the extension of surgery takes place in patients with advanced PTC, with patients with tumor sizes over 1 centimeter. There the differences are clear, and when you look at microcarcinomas, there's no difference. So again, this points out that many patients with microcarcinoma can be effectively and safely treated with lobectomy. But for those patients with more increasing, for larger sizes, I think the extension of surgery should not be an issue in these days. Now, if you look at what kind of surgery was done in patients coming with clinical recurrence, structural recurrence. Well, Kuvaraki reviewed 72 patients having reduced surgery for PTC recurrence, and what these authors found is that Compartment 6 was one of the main compartments involved in recurrence. That lateral disease was overlooked in the first initial procedure, or that the surgeons were plucking the nodes instead of doing a formal compartment dissection. So incomplete lateral dissection was also relevant. And again, I emphasize this because in the slide I showed you previously, recurrence after lateral neck dissection goes up to 20, even to 60%. So the way you perform the lateral dissection of the neck is essential to avoid recurrence. Many of these patients had lobectomy, and they had recurrence to the contralateral lobe, and in some patients, medical suboptimal suppression could be involved. But about 2/3 of patients with recurrence, the problem was initial surgery. The problem was not, too much suppression or high thyroglobulins, the surgery initially was not properly done. Now, for microcarcinoma, there's very little doubt that we can do nothing about recurrence giving radioiodine. This is another controversial issue. We will have discussed that extensively. There is a meta-analysis recently published showing that there is no difference for microcarcinoma whether you give or you don't give radioiodine to these patients. But even for more advanced cases, the recent review by Wendy Sachs from Los Angeles again emphasizes the fact that low-risk PTC or even intermediate-risk PTC are not benefited from radioiodine. This again puts more emphasis on the quality of initial surgery, because in the past, if we follow the Mazzaferris paradigm, we always thought, well, radioiodine would do what the surgeon had not been able to do. But this is over. Now I am more on the Ian Hay Mayo Clinic paradigm, where optimized surgery is going to be, from now on, the first and very important step to avoid recurrences. We cannot trust anymore that the iodine will do what the surgeon didn't do in the first place. That's a nice example of what I call the Mayo Clinic paradigm, where a lady with a low-risk cancer but positive nodes undergoes total thyroidectomy, lymph node dissection, has a good survival prognosis, thyroglobulin is undetectable. We didn't give her iodine, no body scans, no stimulated TCH, just a simple follow-up with a cervical ultrasound once a year and basal thyroglobulin once a year. And she's free of disease 17 years later. So this, I think, will be the next paradigm, which will override what we have been doing on looking carefully and repeatedly to biochemical values. Initial surgery, undetectable thyroglobulin after surgery, and simple and cheap follow-up. Why did the surgeon do incomplete initial surgery? Again, the Kuvaraki, and again, let me emphasize that, they don't address the central compartment of the neck. Lateral disease was not taken into account at the initial surgery, or was improperly addressed from the surgical point of view, or lobectomy was performed. So again, let me emphasize that optimized surgery in 2016, from my point of view, includes addressing the central compartment, whether unilateral or bilateral. You should look for metastatic nodes, which in the end could be the main reason for recurrence. And we don't like to reoperate the central compartment. I've done quite a lot of redo surgery from patients coming from institutions where surgeons were still doing just isolated total thyroidectomies. And what you found when you redo these patients is vascular displacement. The thyroid is out, so the carotid artery and the jugular vein are close to the trachea. Scurry tissues. Some of these patients already come with a recurrent laryngeal nerve paralysis or hypoparathyroidism. The recurrent laryngeal nerve may be at risk when you redo the central compartment. Even the parathyroid identification and preservation is difficult. And 50% of patients coming for reduced surgery in the central compartment also have lateral neck involvement. So sometimes it's not just addressing the issue of going back to compartment 6, but also to go to the lateral neck. And occasionally you find the presence of a thyroid remnant. So that's the typical ultrasound of a lymph node, a paratracheal metastatic lymph node in the central compartment after total thyroidectomy. That's the lymph node, but then you have here your recurrent laryngeal nerve, your carotid artery, your jugular vein, and this is not easy. I mean, this is a surgery that really should be sent to expert people, because going back to compartment 6 is difficult and we don't like it. We have to do it, but we don't like it. Going back to the lateral compartment is not that bad. This lady had a recurrence in compartment 4 after total thyroidectomy and central neck dissection, which we couldn't or we didn't discover that she already or developed a metastatic node in the lateral neck. This is a beautiful metastatic node in compartment 4, but you don't do node blocking. You go up the jugular vein and you do a formal 2, 3, 4 compartment dissection. Node blocking, whereas in the initial surgery or in reduced surgery, is forbidden. Surgeons addressing lymph node resection should address the compartment and not the node. That's also crucial to understand how this surgery should be done. If you have to go back to the lateral compartment, usually the tissues are okay, the surgeon has not been previously there, and then you remove nodes mostly from the infraspinal nodes to compartment 4 and occasionally to compartment 5. Now, how does it work on real numbers? I am a clinician, I am a surgeon, I've done this surgery, and I will try to convey you the message of how optimized surgery results in a given outcome that will allow you to define better the groups of patients that are at high risk of recurrence based on the results of initial surgery. So if you address many of these papers talking about PTC recurrence, you'll see, as Kuvaraki demonstrated, that thyroidectomy is of variable extension in many of these studies. Still, some studies report a mix of PTC and follicular cancer. The definition of recurrence is basic, is very important, because I don't know what a biochemical recurrence as a surgeon. I only understand about structural recurrence requiring reoperation. That's my idea of recurrence. So definition of recurrence is essential to understand what you are talking about. Many studies had low quality or no ultrasound. I mean, to have a good radiologist doing good ultrasound is essential for the endocrine team facing PTC and managing PTC. So if the surgeon is not backed by a good radiologist, a good ultrasonographer of the neck, he's going to be lost, because he will miss many lateral diseases initially and also for recurrence. Microcarcinomas are included in many of these series, and what I call the thyroglobulin madness, or this, let's say, this end of the Matzaferis paradigm, where we are stimulating and recurring and doing this extensive and aggressive follow-up, which I think in large part has been relieved by ultrasound. Ultrasound is a very powerful tool to detect metastasis, much more, from my point of view, than thyroglobulin, even stimulated thyroglobulin. So if you want to keep it a little bit more simpler and a little bit more clinical oriented, I think good ultrasound is essential for the follow-up of these patients. Now, what can you expect from what I call optimized surgery? What's the outcome and what's the risk of recurrence of what I and Cliff Grant from the Mayo Clinic have said it's optimized surgery or optimal surgery in 2016? Now, we've done our series at the hospital in Mar is basically related to patients with advanced PTC. I will not address the issue of microcarcinomas. And for the last 20 years, we have had a very homogeneous surgical approach, what I call optimized surgery, with routine central neck dissection, total thyroidectomy, and therapeutic lateral dissection, where the lateral nodes were involved, selective use of iodine, and only working for and depending on structural recurrence. When I talk about recurrence, I will talk about structural recurrence that has required reduced surgery by ourselves. That's the baseline of our study. You have here the cohort of study of patients that we discussed yesterday, only to point out the fact that they have quite an advanced PTC of 26 millimeters. That, in the Billy-Moria scale, would be a recurrence rate between 7 and 10%, which is pretty close what we have. So again, T size is essential to understand the risk of recurrence. And now let's look at the recurrence rate and the patients that are more prone to present with structural recurrence requiring reoperation. And those are basically related to the lymph node involvement. So for patients undergoing a therapeutic central neck dissection without modified neck dissection, the recurrence rate was 7 out of 38. So now we have a group of patients which have a 20% recurrence rate, which are patients that had a highly involved compartment 6, about 5 to 6 positive nodes in the central compartment, that underwent a therapeutic dissection, didn't have at the initial time a lateral neck dissection, and these are the group representing the high numbers of recurrences. Of 12 lateral recurrences, 7 were found in this group. When you add a lateral cervical modified radical neck dissection at the first step, the risk of recurrence, of course, is much low, and we are pretty happy that we only have 2 recurrences, which mean a 5% recurrence after lateral neck dissection, which I think is a good mark. Together, patients with a therapeutic central neck dissection add up for 85% of the recurrence rate requiring reduced surgery. So this again puts emphasis on the fact that knowing and investigating the central compartment is essential to understand lateral recurrence. Lateral recurrence has been never seen in our institution with, or very rarely seen, only 5% in patients with prophylactic. And all of them had pretty much involved the central compartment. So again, this put emphasis on the relevance on the central neck to understand further recurrence. The number of nodes, the extension of nodes, and where the recurrence has to be expected. As you can see, we haven't had any central neck recurrence. I think this is something closely correlated to our surgical approach, and that lateral recurrence basically is due to a missed lateral disease at the time of initial surgery. Whether the nodes were very small, whether they were overlooked by the radiologist, we don't know. But certainly, we call it recurrence, but obviously this is persistence. These lateral nodes were there at the time of initial surgery, but they were overlooked. So if you want to proceed and to improve your recurrence rate, what we have to stress is the relevance of the lateral compartment to be investigated initially and then at follow-up in patients who have not had or have had a lateral modified radical neck dissection. So this is the true high-risk group. Patients that have a heavily involved central neck and that have not had a lateral neck dissection at the time of surgery, we are talking about 20 to 25% risk of recurrence. Here we are talking about 5% risk of recurrence, and here we are also talking about a 5% risk of recurrence. So this is what basically can be said from the results or the long-term outcome. That's almost an eight-year follow-up, a mean follow-up of 8 years. What can be addressed from a clinical and surgical point of view. There are few recurrences, so the statistical analysis is not particularly brilliant, but you can see the relevance of the extrathyroidal extension, the prophylactic versus therapeutic, which was more common in patients with recurrence. Most of them had a therapeutic approach, whether most of the recurrence of no recurrence had a prophylactic approach. Resected nodes were almost a significant difference. Metastatic nodes were closely to the statistical significance. And again, MACEs didn't help at all to predict recurrence. As many of the scores we have to predict mortality, they are unable to predict recurrence, which probably now is much more predicted by the pathologist when he or she examines the central neck and the T size of the patient. Again, this shows you the risk of lateral recurrence with N0 patients. We haven't seen, except for patients with skip metastasis, we haven't seen almost no recurrence in patients with a N0 central neck. If N1A is below 5, you have a recurrence rate of no recurrence or very few recurrence. That's cases, is not percentages. And when you go to N1A plus 5, almost 40% of the patient will have a recurrence. So again, this puts emphasis on the relevance of the central neck in predicting potential recurrence on the lateral neck. Now, Kufaraki also said that the surgeon is crucial in preventing reoperation. What in the analysis these authors do, they suggest that at least 40% of the reduced surgery for PTC could have been prevented if better pre-op imaging was done. That has to be in close relationship with the involvement of the lateral neck. Or incomplete surgery. The surgeon initially didn't do a lateral neck dissection where there was obvious involvement, or central neck, or limitothyroidectomy, or lobectomy. Or the remnant of thyroid was so huge that recurrence occurred in the thyroid remnant. There was no formal compartment-oriented lymph node dissection, and central neck dissection was not performed. So that's the kind of surgery that was not done and could have prevented almost half of the recurrences requiring reoperation. Now, if you send these patients to surgeons doing more than 50 thyroids a year, probably your surgery will be more close to the optimized type of surgery we are proposing. In this study of Atkinson, they did a study at Pittsburgh University, and on 42 surgeons doing over 1,000 procedures for PTC, and they analyzed that in relation to volume, and they looked at 30 and 50 cutoff thyroids per year, and they were seeing that, okay, time is up. More total thyroidectomies were performed, more central neck dissections were performed, best post-op DG labels, and very much less expensive follow-up. And this last slide shows you the impact on complications and volume. So in this slide, you see surgeons doing 10 thyroids a year compared to between 10 and 100 and over 100. And you can say that both for goiter, Graves' disease, and thyroid malignancy, volume makes a difference. So in conclusion, our 8% recurrence rate is reasonable, and I think that's the best that we can offer now to our patients with optimized surgery. That routine central neck dissection in our hands has eliminated central neck recurrences, which are very nasty to reoperate. The central node involvement is a very good predictor of lateral recurrence and has to be looked at as a main risk factor for lateral recurrence. The lateral recurrence is a secondary procedure in many of these cases, needing redo surgery, and that surgical treatment of PTC is probably best performed in specialized units providing optimal surgery for these patients. Thank you.